Hi, my name is Emma. I'm a PharmD Candidate. This is a Med Ed 101 production, a video within a series that's describing potential clinical guideline updates, and it is essentially a mini journal club. So we will talk about some background and then go over a paper that was just published. So this paper is going to be discussing beta blocker use after MI and preserved ejection fraction. So the objectives of this presentation, we're first going to start with the mechanism of action, so reviewing the MOA for beta blockers in both heart failure and post-MI, look at place in therapy for both post-MI and heart failure, describe background trials that lead to the current trial, and then we're going to detail the REDUCE AMI trial and highlight important findings. So first, mechanism of action. So within heart failure and post-MI, there's direct antagonism of cardiotoxic effects of catecholamines, upregulation of myocardial beta receptors, and suppression of neurohormonal systems like RAS, and prolongation of the diastolic phase with improvement in coronary flow. So this overall leads to improvements in the structure and function of the left ventricle, reducing heart rate and blood pressure, and reducing burden of arrhythmias and anti-ischemic effects. So what is their place in therapy? So as you may be familiar, post-MI, we typically prescribe beta blockers for at least 3 months, ideally 3 years, and especially if the ejection fraction is less than 40%, we do it indefinitely. For heart failure, beta blockers are a pillar of HFrEF, so reduced ejection fraction, but not proven beneficial yet in heart failure with preserved ejection fraction. So let's now describe some background. So we are looking at 2 background studies. The first one describes clinical outcomes between beta blockers and post-MI. So the 2014 study found that beta blockers have no mortality benefit, but reduce recurrent MI at an expense of serious side effects. But we compare this to the 2021 trial and look at beta blocker use post-MI with no heart failure, and they found that beta blockers reduce risk of all-cause mortality and MI in patients younger than 75 without heart failure. So now we're going to build upon that and look at beta blocker use after MI plus heart failure with preserved ejection fraction. So that brings us to today's study, which is REDUCE AMI. So the main objective of this study was to study the effect of long-term beta blocker use in patients post-MI with preserved ejection fraction. So the trial was registry-based, prospective, open-label, parallel group, randomized, and multinational at 45 different centers. Patients had acute myocardial infarction and left ventricular ejection fraction of over 50%. And the primary endpoint was composite of death from any cause or new myocardial infarction. And then the 2 groups were beta blockers with 2,500 patients and then no beta blockers with 2,512 patients. So for results and conclusions, so they did find after 3.5 years, groups did not differ significantly to the composite endpoint, which was again MI recurrence or death. Safety endpoints were similar between groups. However, big stipulation here, there were large issues with this study. So as you may have picked up on, it was open label design, and there was a large crossover at 14% with patients who were assigned to not take a beta blocker being prescribed one. So there was a large margin of error that occurred with this study. So, as you might suspect, I would say this does not change practice due to the low confidence of this study with that open label and large crossover. However, I think it is very much worth looking into whether beta blocker use is appropriate in this population, as there is, I think, use case for this information. Here are the references I used for this presentation. And thank you so much for listening. If you have any questions or comments, please comment them down below. And I appreciate your time today. Thank you.